am really excited for today's episode. Today, we are going to deep dive into radiology. This is a topic I have wanted to talk about for a very long time. I think it's similar to the pathology topic that we covered a few episodes ago, but this is a topic that is so important to clinical care, yet it's one that I don't think patients fully understand, nor do we get to interface with the radiologists who are working on our case and reading our scans. So I'm just really excited today to dive deeper into exactly what happens when a patient has a scan, exactly how radiology works, and many other topics. I'm actually also excited for our guest today. I'll have Costa introduce himself in just a minute, but Costa and I have known each other since before my diagnosis, and since my diagnosis, about 6 years ago, he and I have collaborated quite closely on my own case. So I look forward to learning even more from him today. Costa, why don't you go ahead and introduce yourself?
Hi, I'm Costa Raptis. I'm a professor of diagnostic radiology at the Mallinckrodt Institute of Radiology in St. Louis. That's part of Washington University in St. Louis. And my sort of subspecialty within that role is I'm in the cardiothoracic imaging section. So I specialize in basically imaging of the chest, but I do body imaging of all types. So chest, abdomen, emergency department. And pertinent to this conversation today, I do a ton of oncologic imaging, both in initial diagnosis and follow-up.
We are very excited to have you here. So thank you for joining us. And I think I'm just as excited as Julie is for this episode. I think this might be one that we started talking about when we very first started the podcast, of how much we wanted to do this kind of episode. So I think that was even highlighted in some of our early episodes where we talked about our own confusion with diagnostics and when we were first diagnosed. I know for me, I didn't really know anything about cancer when I was initially diagnosed, and I heard of everybody going for PET scans, but my very first scan was just a regular CT scan. I later was sent for MRIs, and it left me in this place of wondering, am I getting the right scan? Do my doctors even know what they're doing? Which I would later learn that you use different scans depending on what you're looking for, and oftentimes in the different types of cancers as well too. So I thought that that might be a really good place for us to kick off with, and was wondering if you can help describe for us what the different imaging modalities are and when they might be used in different scenarios.
Sure. So, I mean, radiology is sort of like, what is radiology? Radiology is sort of the study or the medical part, the medical field of diagnostic imaging. So that includes imaging modalities that involve radiation, and it actually involves imaging modalities that don't involve radiation. It's basically all imaging of the body falls under the field of diagnostic radiology. And there's a lot of different modalities that we have available to us. We've got, just our basic stuff with 2D sort of flat plate, what we call plain films. So your chest x-ray, right? So that's an x-ray as part of diagnostic imaging. That's a 2D image, and you can take it in multiple projections. You can do it of the chest. You can do it of the abdomen. You can do it on someone's arm to look if they have a broken bone. That's a very versatile test. And it's used basically to identify specific things, just like all things in diagnostic radiology are, depending on the patient that's involved and what the quote clinical question is. So start off with diagnostic imaging. You say, well, first thing is, plain film. That's the most basic thing. But as radiology has evolved, we have much more sophisticated tools today. So we have CT scans, which, I mean, I think the best way to think about that is sort of a 3D X-ray. Okay, it's using radiation, but it presents us with imaging of the inside the body, whereas a radiograph is a 2D image. Your basic chest X-ray is just 2D. A CT allows you to look inside with slices of the patient in different projections and gives you a more detailed look at the organs and soft tissues and other structures inside the patient. Then there's other things like MRI. MRI doesn't use radiation. It uses a different type of technology. And that also gives us pictures of the body. It's a little bit longer in time to acquire an MRI versus a CT. And some people think, oh, an MRI, it's better, it's more sophisticated. That's not necessarily true. A lot of times it depends on the question that somebody has. An MRI is very good with soft tissue contrast. That means like its ability to distinguish one structure from another. But what's known as spatial resolution, like how small the pixels are, not as great with an MRI. So for some things, MRI is very good. For other things, MRI is not as good, and we prefer a CT. There are other modalities beyond that. We've got ultrasound. That's part of diagnostic imaging. That can be very helpful when targeted at specific parts of the body. A doctor or an ultrasound technician can use an ultrasound probe without radiation to look at an organ and identify different features of that organ, oftentimes that are complementary of CT and MRI. So you think ultrasound, oh, maybe ultrasound is worse. It's not necessarily worse. It's just different. And then you get off into sort of newer, I don't want to say more exotic things because they're commonplace now, but slightly more complicated things like a PET scan, which is a fusion of, in general, a fusion of a CT and a nuclear medicine study. And nuclear medicine is a subspecialty within radiology in which patients are given some compound, either orally or intravenously, and that compound gives off radiation, and then we detect it. Okay, we detect the counts from that. We make an image based on that. PET scans and PET CT, what we do in that field is we basically give the patient some compound, they emit radiation, then we take that map and overlay it with a CT, so we have sort of the anatomic information and sort of the functional or metabolic information. Why are PET scans so prevalent in oncologic imaging is because the most common form of that is FDG PET, which is basically a measure of metabolic activity. Tumors have higher metabolic activity. So we can use that modality to sort of localize tumors at a higher sensitivity than we might be able to on CT or MRI, where we're just getting what's known as anatomic information. Like you have a structure here, and then we have to try to figure out what that structure is. We may not know if it's a bad structure or just something normal or something benign. Sometimes PET can help us with that. So, radiology is a very big field, and it's not just one thing. And most radiologists, I think, interact with or read a combination of these modalities. Not all radiologists read all of them, but we read most of them. And what study gets ordered on a specific patient often depends a lot on the clinical question being asked. So specifically, what is the doctor ordering the study trying to find out? So I think it's not always a great idea to read too much into like, oh, I didn't get a PET CT, and PET CT is like, expensive and sounds impressive. That may not be what you needed. So all of these things kind of work together to get us information about what's going on inside a patient, essentially.
It's a very common question that patients will ask, like, am I getting the right test? I wanted to just validate that actually doctors ask that quite a bit. One of the things I'll ask the radiologist and tumor board often is if we're trying to answer a specific question, what test is best to answer that question? Radiologists are really a wealth of knowledge for that kind of an answer. And just I really want to drive home the point that like there's no one best test. It really depends what you're asking to really determine the answer to that question, I think.
And a lot of times what will happen is in the real world, either at a tumor board or just on reading a scan, is a patient might start by getting an ultrasound or a CT scan or X-ray, and we'll see something on that imaging modality that will prompt us to recommend another imaging modality to sort of add information to try to figure out what we're looking at. So oftentimes they kind of go in sequence or in series, and we'll use them together to try to get an answer to a question, essentially. And so, yeah, as radiologists, we do kind of have a feel for that. Like, some of it's not like straight science. It's like I think that this other modality might help me, figure out what this is. But that is basically how radiology works and ordering of studies works.
So we had an episode on tumor boards at the very beginning of our podcast series. Are radiologists always at tumor boards? Is that pretty regular?
Yeah, I think that most tumor boards involve a radiologist, and probably most of them are kind of centered around a radiologist, because what ends up happening is, the patient will be presented, like their clinical case will be presented, and then the radiologist will like show the imaging, so everybody has an idea of what kind of they're dealing with. And then they can talk about the patient from a clinical perspective, and the radiologist may sit back a bit. But radiology is very important in tumor boards because it allows for the interaction of the radiologist with the other doctors to kind of really show what specific things are of interest or of concern on a specific imaging modality, and the imaging studies are often sort of the centerpiece of the patient's sort of clinical information.
I just had a question about that. As far as like the tumor board goes, and I'm thinking more of in a community setting when you're involving a radiologist, and a community oncologist might be ordering a scan. I know, especially as medicine moves forward, there's all kinds of different tracers. I think you kind of mentioned one with the PET scans. And I know that there's different kinds of PET scans using different tracers for different things. So for example, in kidney cancer, when I shared how I was really confused because I didn't get a PET scan, and that was just this traditional, is it FDG? I don't know the exact letters there, but
FDG, yes.
yes, the typical kind of PET scan that I think people normally think of. But in kidney cancer, that's not often used because I believe it secretes in the kidney and can make it hard to see tumors in the kidney. But then there's
Correct.
other scans that are coming along that are newer, that are based on tracers that are often found in the most common types of kidney cancer. And so, how much does maybe a community radiologist know, or how do they keep up to date on those to know the differences for each of the cancer types?
Okay, so full disclosure, PET scans and all of that arena of that's part of nuclear medicine, which in my practice at a big academic center is handled by specific doctors who only do that. But I know quite a bit about it, just as, in being part of tumor boards, so I can kind of speak to the question. I'd say at large in the community, almost everywhere, you have access to FDG PET scans today. And FDG PET scans are good for some types of tumors, a lot of tumors, but other types of tumors are not good for. Some tumors aren't what we call FDG avid. So they happen to be tumors that don't demonstrate high activity or don't take up the FDG. So an example of that would be a carcinoid tumor in the lung. Notoriously, it may give you a false negative result on an FDG PET. Some adenocarcinomas in the lung may not be FDG avid. So you'll have a mass and you'll do an FDG PET and it will be negative, and then people will think, or a consolidation or whatever. And people think that it's not a tumor, but that's just because the tumor doesn't take it up. Other drawbacks of FDG PET are what you said. Some organs have a lot of background activity. The kidneys have a lot of background activity. The liver has a lot of background activity. So it's hard to find tumors in that. You're like, I'm not sure if that's just like some normal area or if it's some increased activity. Now, there are lots of new radio tracers that are being developed. Most of those are sort of like new/research oriented and would be found at sort of like a tertiary cancer center. And their utility is kind of still being discovered, right? So just because there is a radio tracer that can do something doesn't mean that it actually needs to be used in like every single patient who has X disease, right? It would only be if there's a specific question. So, when it comes to the question of would I expect like a community oncologist or radiologist to be familiar with all of these radio tracers, I probably wouldn't. And they're probably not. But they probably are very familiar with like FDG PET, which is something we use commonly. And I think as, more research is done with those radio tracers, the ones that are the most robust and have the most benefit, they will end up getting filtered out, to smaller practices to be used more regularly. I think at this point, like most of those things, you only find in like a big center. And that's really what it comes down to. The other issue with those radio tracers is they need to be produced, and you need oftentimes like a cyclotron and other things to do that. And so that also concentrates them towards larger centers. Like it's hard for a small place to be producing like all these novel radio tracers. So there's multiple reasons why those things are concentrated in a big center.
One good example that really quick that the audience might be aware of is PSMA PET is a scan that's now become standard of care in prostate cancer. It's had a big impact on the field, really helpful test. I remember when I was in training, that test came out and it was initially only available at two big academic centers. And so patients could go there and get it if they wanted to. But that was the time where it was sort of being figured out as how useful it was going to be. And then I think because of some of the production issues, it was available mainly at these centers. Nowadays, it's only a few years later and it's available at basically every center that I've seen, at least in the community that I work in. And like every community oncologist is familiar with it as a standard of care, and now everyone gets it. And so it does trickle through pretty quickly, but I think it's a really good explanation that you just had about how they tend to start in like these innovation centers where they start producing them and then it becomes commercialized.
So maybe we can talk a little bit about the actual scan. I know, Katie, you probably have nightmares about or dreams about the guy who says, "You may now breathe." You know, like I always feel like that is what patients think
That's
of.
usually a recording.
I know, but it always comes up. And when you ask patients about scans, that's like the first thing
Yes.
that they talk about is holding their breath and then the recording that tells you breathe. Anyway, I think it would be helpful if we just started all the way from the beginning and talked about what's actually happening when a patient gets a scan. And then, we can even transition to, the patient obviously knows what is happening in that process of getting the scan. But the piece that's always been a black box for me is when the scan is over and I leave that room, the period of time between the scan ending and then me sitting in the physician's office getting the results. We can touch a little bit on not only what happens during the scan, but what also is happening behind the scenes between those time points, I think would be really enlightening.
I also will add, if talking even about the breath holding, if you want to even just touch on that briefly I think of breathe in, breathe out, hold your breath. And then I'm thinking,
Yes.
how am I holding my breath? Am I like getting rid of all of it? And now I'm like, I might die on this table. I can't breathe in. So if you could help explain the purpose of that. And then
Sure.
I've in time also learned to know a lot of that's more about consistency. But I think that's really helpful because patients don't get any more instructions in that very short recording.
So, okay, so starting from the beginning, when you go into a radiology department to get a study, you're going to be interacting primarily with technologists, and their job is to obtain an image, whether that's a radiograph or a CT or an MRI. Their job is to run the machine to get the image from the patient. And honestly, I know how to run some parts of the machine, but like if you told me, oh, like go do the CT on Mrs. Jones, like no chance I'd be able to do that, right? That's their area of expertise. But I can come there and help them. I can set up the planes or the part of the body that we want to look at. And there's little modifications that I can do to kind of improve the scan. When it comes to what you can do as a patient to make your scan better, that breath holding part is actually super important. So whether it's a CT or an MR, there is some period of time in which, the machine is acquiring the image. Actually, on an MR, it's much longer. CT, it's shorter. And the reason why it's key to hold your breath is because then you don't move, right? So if you're breathing during the scan, particularly if you're looking at the chest, it's going to be all blurry, right? Because you're acquiring the image and your body's moving while you're acquiring it. You're going to have a ton of what's called artifact, and it's going to make the study hard to evaluate. So a good breath hold is like literally the most important thing for any important patient to do. Now, there's different ways you can instruct the breath hold. You can have the patient take a breath in and hold it. You can have the patient take a breath in and blow it out and then hold it. You can have the patient stop breathing, like just stop breathing. All of them have different strengths and weaknesses. I think the most common way to do it is what's called an inspiratory scan. So the patient takes a breath in and hold it. An expiratory scan, which is breath in, breath all the way out and hold it, produces a bit of a different image of the lungs because your lungs are kind of like semi-collapsed, the alveoli are collapsing. So we do use that to answer some questions, but that's sort of not the standard. But the bottom line is that you really want to make as good of an effort as you can to whenever they want you to stop that breath hold. And a good technologist will kind of like prep you ahead of time, like, I'm going to ask you to do a breath hold like this, right? And so you have some idea of what you're doing, not like this recording comes out of nowhere and you're like, what is happening? And then once you get to whatever the breath hold is, you try to stay as still as possible. Like, don't move your arm, try not to swallow, don't cough, don't turn your head, don't do anything, right? Just sit there, right, for the period of the scan. Now, for a CT, that's like super fast. It's like seconds. It's like, and it's over, right? You hold your breath, it's like, done. MRI is a little bit different, right? MRI can have like breath holds 20 seconds, even longer, and there can be lots of them, right? So CT is like usually one or a few acquisitions that are very fast. MRI can be like 50 breath holds in a long scan, and that can be tiring. You know, that can be really tiring to do 50 breath holds. But the most important thing is you try to do your best to stay still. If you're doing an MRI, this is the last point on the MRI and the breath holds, or the last point on the breath holds, and you like feel like you're gonna not be able to hold your breath, the best thing to do is just let it out really slow, right? Don't just like, right? That's a lot of movement. Just like try to breathe out really slow, right? If you have to. But that's what the breath hold is for. The breath hold is to prevent moving. It's to prevent your inside of your body from moving. So that's question number one. So the first thing that happens is you interact with a technologist obtains the images. And keep in mind that based on the type of study that you have, you may or may not be getting an IV. The IV would be used to give you contrast, intravenous contrast. And that's not always needed. Some studies you need intravenous contrast. Some studies you don't. Sometimes you actually don't want it. You would prefer to not have it. Sometimes you'll get scans with and without intravenous contrast. So you may be getting an IV to put the contrast in during the exam. So you get the study done by the technologist and then you leave. So what happens to the exam? So basically, the exam is sent, the images are sent to a work list. That's basically the best way to describe it. They get sent to, in 2025, to a work list. And your study sits on a work list. And then a radiologist is going to come along and read it, right? So that could happen like that day. It could happen some other day. It depends on the acuity of the scan and the practice that you're going to. Now, at the place where I work, pretty much everything gets read the same day, but that's not really like standard. So if there's like a delay in your result, it's not because there's something wrong. It's probably because no one's read it yet. So when somebody is going to read it, who's going to read it? The radiologist is the person that reads it. Where are they? They could be a lot of places. Okay, so the radiologist could be at the imaging center where you got the study, whether that's some outpatient thing or a big hospital. The radiologist could be in another hospital. The radiologist could be at their house, right? So I'm sitting here on my Mac, but like next to me is my radiology computer, which is known as a PACS computer. That's the name of a radiology computer. And I read radiology like from my house. So that's all equivalent. And at some point, a radiologist is going to take a look at your scan. So what does that mean? So when a radiologist looks at their scan, your scan or your study, they pull it up. And if it's a cross-sectional imaging, meaning a CT or an MRI, they're able to scroll through it, able to look at all the images. And as they're doing that, they're going to generate a report, a written report. It's dictated into a computer. So it's a voice-recognized dictation. And that report has different parts. One part is the findings, which is where we kind of describe what we see. Okay, there is a mass here. This is normal. There's nothing over here, etc. List of findings. And then at the bottom will be what's known as an impression. And the impression kind of takes those findings and tries to put them in some context. So, you might say something like, there's a 2-centimeter mass in the kidney that's suspicious for renal cell cancer. Or there's a 4-millimeter nodule in the lung that's indeterminate. That means I don't know what it is. And you may recommend follow-up based on that, or you may say everything is normal. The purpose of the impression is to take those things you saw in the findings and kind of give them some context to direct the reader of the report what they need to do with the results, or what they need to do with the patient, or what the exam showed. And that honestly really is it from like start to finish. Like, you're going to get the exam is going to be sent to a list. A radiologist is going to look at it. They're going to make a report, and then it's over. Like, the report goes out. That report gets put into the medical record. Based on the hospital you're at, there's some hospitals where your patient can actually see the report before they see their doctor. I actually don't think that's a great idea, because some of the findings that are in things that are described in reports, like a person who doesn't have a whole lot of background would not understand their significance or be able to understand them. It causes a lot of anxiety for no reason. Or you may have to wait until you see your doctor, in which time your doctor will like review the results with you. And I think that's actually the optimal way to do it, because they can kind of filter the information that comes from your radiology report, which it's important to keep in mind is just one piece of information, with everything else they know about you, and say, this is what's important from what we saw in your exam, right? It may, some of it that is described in the radiology report may indeed not be important. And so that's why a good oncologist or good doctor who's ordering the scan will be able to take that radiology report and help the patient understand it and what it means in the direction of their treatment. So that's kind of what happens from start to finish.
Just curious, on average, and I know this is probably going to differ based on the question that the radiologist is asked to answer and the type of scan and things like that, but I guess on average, how long does it take to read something like a CT of the chest, abdomen, and pelvis? Is this a 5-minute activity, an hour-long activity?
It's not an hour long. It depends, right? So it really depends on what's on the scan. So if the scan is normal, there's not like a lot going on. Like, for example, your scans, they take me, I don't know, 3 minutes, 4 minutes at most. You know, like I can read your scan pretty fast. It's near normal. I know what's on it. 4 minutes, I would say on average. But a complicated scan with a lot of findings, or that you have to think about, I can take 30 minutes on a CT scan if it's really complicated. So there's a huge variation in how long it takes to read a CT scan or any imaging study. MRIs take longer than CT scans because there are more images and more sequences and like more things to click through. So an MRI, even a normal one, is more on the order of like 5 to 10 minutes, just because of the amount of clicking and scrolling and moving things around that you need to do. CT is pretty much like 1 or 2 data sets, and then that takes not too long to do if it's normal. But it can get complicated, and the more complicated ones take longer.
And how often are you going back and referencing things on past scans?
Yeah, I mean, that really is like, particularly in cancer follow-up, looking at the old scan and the old report, having it there for comparison, it's like essential. So, sometimes we'll have patients who come to our institution and they're in like the middle of their cancer care. So they've had all this stuff done, but they don't have their prior exams. And then they present with like some CT imaging with like 20 findings. And I don't know the relevance of any of them, because I don't have, a comparison scan or scans to look back and be like, oh, this thing has been here for 5 years. I don't need to worry about it. Oh, this thing is a scar where there was a treated tumor. I don't need to worry about it. So those old scans are super important, both in terms of like the images themselves, like I see something here, then I look at the old scan and compare it. And also I get to look at and I usually do this after I've reviewed the study that I'm looking at, but I get to see the old report. So the radiologist that looked at the old report noted X, Y, and Z. I can make sure that I also describe or look at X, Y, and Z. So having the old studies is super important, and especially in cancer therapy and cancer follow-up, you really need to have them to go through an imaging study.
So one point that was made in passing that probably is worth pointing out is that when you have a quote normal scan, like it is not like you scan 50 people and they all look like the textbook image of a CT chest, abdomen, pelvis. Everyone looks different, right? And they all have different things going on in their body. A lot of times those things could be not relevant to the patient's cancer, but you can't really tell. And the way you would tell is by like looking back or looking forward, maybe even looking at the doctor's notes to see what they've brought up or what kind of question they're asking. And so people really like a really, really important point is that like normal is pretty variable from patient to patient. And so a big job of the radiologist is to try to read our physicians' minds and to try to figure out what exactly we're asking. We don't always tell them well, and then try to help us put that in context of the rest of the scans and the rest of the care.
Yeah, that's a really good point. And that's part of why I like the impression. And radiologists have different styles of dictating reports. Some radiologists will, in the impression, I mean, list off everything, even if it's something that I would basically ignore and put in the bin of normal. So, to me, normal may not mean that you have like the perfect pristine organs with like zero findings. You may have some findings, but they're not important findings or not findings that are likely to cause you any harm. So you still get to be normal. And everybody has slightly different. Some people have cysts in their kidneys, and some people have cysts in their liver. Some people have small pulmonary nodules or calcifications in their spleen or whatever. And none of those things matter. So they still get to be normal.
I think.
Yeah, I'm just laughing because ever since I started scanning, Costa knows this really well. They always call out my liver, and I always
Julie
worry.
does have a very strange looking.
I have a really strange looking liver that my liver's totally normal, but this is a good example of something that, is in that range of normal, but may not be kind of what the textbook normal looks like. And so for 6 years, my liver is constantly mentioned. And I know now to ignore it. But for many years, I was always suspect. Like, if it's normal, why are they even mentioning it? They must be mentioning it because it's abnormal. And I guess it looks abnormal, but is actually just fine. So I'm just an example of exactly what you're talking about.
Right. I mean, and I think that in your case, it illustrates, I think, nicely is that, I've seen all of your scans from the first scan. So I sort of know what was there, like at the beginning, and this liver always kind of looked like this, and it never has changed. So, it's just some variation of, like you said, it's a little bit different, but that doesn't mean that it's anything to worry about. And that's really important. Like when you start to get down to it, and I can tell you that in looking at my own imaging, like you can make, if you know like a little bit, you can make yourself totally insane by like, well, what about that thing right there? Like, I mean, I don't know what it is, but it probably doesn't matter, right? So the reality is that you need a good radiologist can help you kind of like ferret out what is something you need to worry about and what's like within the spectrum of things you don't. And your liver is definitely a good example of that.
I think another like thing to highlight there that I think I heard you touch on too is like some people have cysts in their kidneys, some have them in their liver. I know it's and this is something I did not know prior to my diagnosis, is that it's relatively common to pick up like very small nodules in the lungs, like under like ballpark of I think 5 millimeters or around there. I think under a centimeter for sure. And I know that that's something I was worried about. I see it all the time in support groups, like these little tiny nodules that'll pop up that somebody is really worried about. And I'll just share from a personal experience there. The very first time I had one of those, I mean, I had some that were discovered initially when I was diagnosed. They haven't changed over time. But I had a new one that popped up very early on in my diagnosis, and it was about 6 millimeters. And I remember being petrified because all of a sudden I had this new thing that popped up while I was responding to treatment for everything else. And all I had to do was sit and wait for 3 months to figure out what that was. And it was gone on the next scan. But eventually, talking with other patients and other people, I kind of had put two and two together that right before my scan, I had like gotten a little too eager about eating some like cake batter ice cream, and I'd like inhaled and like choked or aspirated on like food or something, right? But and that might have been what that was in my lungs, and it was completely gone the next scan. And so, can you touch on kind of those lung findings that might be kind of small and how you are able to determine like something that's worth following up on versus something that you just watch?
Yeah, so lung nodules are a huge part, especially of chest radiology. So, I mean, what you said is absolutely correct. If you start scanning people who are 50 years old who are normal, you're gonna, or like let's say in the ED who are there for trauma or whatever, you're gonna find all kinds of lung nodules. Particularly if you live in the Midwest, we have a lot of what's called histoplasmosis here, which is an endemic fungus that you get exposed to and can lead to small nodules in your lungs. They often calcify. It's nothing. It's benign, not a big deal. But you can have nodules for all sorts of reasons. You can have nodule because you had an old infection there. You can have nodule because you have an active infection there. Can have nodule because your dog had a worm and then you got exposed to the worm and you got something called diarrhofilarial nodule. I mean, there's like this huge, you can have a nodule that's a lymph node in your lung and is normal. There's this huge spectrum of reasons why you could have a nodule. One of them is, in fact, cancer. Right? So the nodule could be a primary cancer of the lung, or it could be a metastatic lesion in somebody who has a cancer somewhere else. That's why everybody's like so focused on the nodules. There are a lot of things, though, that we can use to kind of help us try to figure out, this is a nodule I'm worried about, this is one I'm not worried about. So the best thing is old scans, right? So if you have an old scan and it's like, oh, I found this 4 millimeter nodule, but then it was there 4 years ago, then you don't worry about it, right? That's a nodule, it's just there. And in the other direction, you have a nodule, which may end up happening to you, and you'll say, oh, there's this nodule, and maybe it's new, or you don't have any priors. It's like the first time you've seen the patient, and you have some nodule. It's really small. Your only option at that point is to get a follow-up scan, right? And be like, does this grow or does it not grow? Does it go away? Like, what happens here? And based on that, then you can kind of like determine whether you need to pursue further diagnosis of that nodule, which would involve either biopsying it, which is an involved thing, or taking it out, right? So that would be like the next step. And we like to try to avoid that if it's a benign nodule. That's one way of doing it, using sort of time to your advantage, and that's probably the most common thing. There are some imaging features of the nodules that can help us. Number one, calcified nodules, usually benign. There are some patterns of calcification that aren't, but usually benign, or almost always benign. Nodules that are clustered, like a bunch of nodules next to each other, often benign, usually related to, like you said, aspirating or an infection. There are features of nodules, like if there's fat in the nodule, that's usually a benign finding. It can be something called a hamartoma, which is a benign lesion of lung, or aspirated fat. There are some features that would be considered concerning. Irregular borders, something that's called spiculation, which is like spikes out of the nodule. Those are concerning. They tend to be more concerning on the spectrum of a primary lung cancer than they would a metastasis. Metastases are usually smooth, round nodules, or multiple of them often. And then finally, if a nodule is big enough, typically over 1 centimeter, we can do a PET CT on it. PET CT can be helpful for nodules. The problem with PET CT is this. Number one, if the PET CT is negative, that is reassuring. So if you've got a larger nodule that's not avid, that's probably a good sign, particularly if you have a cancer somewhere else, unlikely to be a metastasis. But I did tell you earlier that there are tumors, and some of them are lung tumors that aren't FDG avid, so it could be one of those still. The other problem with PET CT, and I think this is the bigger problem, is if you have a patient who comes in, new nodule or baseline scan nodule, and you do a PET CT and it's avid, that doesn't help you a whole lot because there are many benign things, mostly infectious, that also would be avid. So infections and cancers can be avid. And in that case, you might be kind of up the creek with either getting a biopsy or getting it removed. But lung nodules are, I mean, we see so many of them. And I don't want to say I've learned to ignore a lot of nodules, but I have learned to ignore them. I mean, I see lots of nodules that I don't put in reports because I know that they cause anxiety, and either I know they're on an old scan or I'm like a very high confidence level that they don't matter. But the harder you look, the more you will see. And so lung nodules are something that often require follow-up, and unfortunately are something that as technology's gotten better, we've just been able to see way more of.
I think this is a really interesting point for those that don't have cancer, or for those that, like, I know, especially my diagnosis, right? Like, I know, Julie, I don't know if you had this, but my diagnosis, I think, sparked fear in a lot of like my friends and family, who then it's front of mind for them. And like, I think everybody naturally worries about cancer, right? Like, back to the days of WebMD, like any symptom you typed in, people thought that they had cancer. And I know there's new like modalities now where people can go get whole body MRIs and all these other imaging modalities. And I think this is really important context to think about in those situations, because I know earlier you mentioned how you think patients having access to a report can cause a lot of anxiety that there might not be needed. And it's something I think a lot about when I think about, one, I was somebody that my cancer was missed for a long period of time because nobody was willing to put me through a scanner. um, but at the same time, like, I am a rarity, like in every form. Like, what happened to me, like, statistically doesn't happen most of the time. And so when you talk about like how common these lung nodules and things like that are, it's much more common, I think, for somebody to end up in a scenario where they might find something and then they're going to have to go through a period of time of pure terror for 3 months, wondering if they have cancer or not, until they're rescanned to get the clearance, and know it's good. And so it's something I think a lot about, as like somebody who has had cancer and been in that very like rare scenario that I wish I would have had a scan, but also knowing how common other findings are as well too. I don't know the answer to that scenario, but I think it's something people should think about.
I think a
Yeah,
lot of people don't realize that like there's no scan where you put someone through a scanner and the report is like, this is this type of cancer, it's this stage and this diagnosis, and this is what it is. It's actually like the total opposite, where I think what Costa, your explanation is really nice of those lung nodules. It really shows how challenging it is to tell the difference between something that can be very worrisome or not worrisome at all. And sometimes we're not even sure, and you need more than one scan to be able to tell the difference, right? And so like I think if the lay public had a better understanding of that, they might see why, for example, some doctors are not so enthusiastic about these full body scans on a healthy individual, because it doesn't always help you the way that you think it might.
yeah, and I mean the other thing that you really have to think about with a full body scan, and there's a lot. That's an area of research, like full body MRI, that kind of stuff. But you know, one thing that you're going to get with full body MRI is a certain percentage of people are going to have to undergo a workup for something in them that's not a problem, that's benign. And that workup is going to carry risks, right? So like you may need to have a lung nodule taken out, or you may need to have a study to stick a scope down inside you to biopsy something that we saw on your scan that was incidental, meaning it just happened to be there without any symptoms, to biopsy something and say in your pancreas, or to biopsy your kidney, or whatever, right? So there is a cost, both in terms of anxiety, which I think is a huge cost. I think anxiety is the biggest cost, right? You start telling people that they have like an abnormality, and they immediately, and I've done this with myself, they immediately default to the worst case scenario of what that thing could be. That's number one. Anxiety is very bad, and it causes other issues. But number two, if you have these incidental findings, you may have to undergo a surgery or other procedure to figure out what it is. So, there are pluses and minuses to looking at somebody who doesn't have like an indication, like a symptom, to just kind of like go on a goose chase, right? You think that like, oh, well, if I do this imaging, I'll find everything that's wrong with me and we'll fix it. I mean, that's not necessarily true, right? Like that may happen in some small amount of people, like, oh, we scanned somebody, found this incidental thing, and we fixed it. Or if somebody is at particularly high risk for a certain kind of cancer, like for example, patients who have a big smoking history, we have a lung cancer screening program in which they're asymptomatic, but we scan them for lung cancers. Effectively, we do CT scans that are low dose to look for early lung cancers. That's taking a patient who's at risk and has an indication to try to find somebody. If you take a totally healthy patient and you do that same thing, you're not going to get that same risk benefit ratio, right? It's going to be a lot of risk for a small amount of benefit. So it is tricky about when to order a scan. And then, you're going to find things on scans that you weren't expecting. pulmonary nodules, things in organs, and those are going to involve follow-up, and there's downstream consequences of that. You are opening a little bit of like a, you know, Pandora's box when you get in that realm.
So I think maybe kind of feeding off of that, and we like kind of bridging back to the cancer space. We know how long it takes to kind of read some of these scans. We know all of the subjectivity there is. Can you talk a little bit more about that? Also including, I know something for me, for example, in the past on my scans, we talked about those like lung nodules. I think patients can really worry about those if they might see them in their lungs. But also, I know on my scans, I pay really close attention to the measurements. So can you talk a little bit about how the measurements are done? I now know that there can be some variation in those, but that's not something that I knew early on. And so can you talk a little bit about how the measurements are done on scans, as well as if you have any tools or safeguards in place to make sure that things are done consistently or don't get missed, or kind of what that process looks like?
Yeah, so measuring is a huge part of cancer follow-up because, you know, the biggest question that everybody wants to know is this thing bigger or smaller or the same? Bigger, smaller, the same? And how you measure a lesion can vary between the person looking at it, right? You pull a lesion up on a slice, so on an image, and then you could measure it like this, or you could measure it like this. You know, you have your choice. Right now, there are some standards. So for lymph nodes, we measure the short axis of the lesion, meaning the shortest dimension that we see in axial image. That's the standard for lymph nodes. Not everybody does that, but that's how you're supposed to do it. You're supposed to measure the short axis because it's the most reproducible, and it's the number that we have the most data for in terms of like what's an abnormal threshold. So if you've got a lymph node that's like really long, but it's not that fat, that's okay, right? Because the short axis of the lymph node wouldn't be that big. So I'm looking not at how long it is, but the width of it, the short axis. For something like a pulmonary nodule, we usually measure long axis, or both, or two axes, or even three axes, meaning we get another plane, like a coronal or sagittal, like frontal or sagittal, which we can take our images and make those pictures. And, you know, you basically do like an orthogonal, meaning you bisect the lesion and give like, you know, 5 by 6 millimeters or 8 by 7 millimeters. Now, I think what you're really getting at with the question is, like, there's variability in measuring things, and that can come from a lot of different things. One, it can come from sort of which orientation we use to make the measurements. That's the biggest thing, right? So if radiologist A picks this way and radiologist B picks this way, you might get something slightly different. Number two, these lesions are often, they're not often, they are in other organs. And like where you draw the border of the lesion, like this is the end of the lesion and this is the organ, or this is the end of the lesion and this is like some benign blood next to it or something like that, can vary amongst people. And actually can vary amongst scans. So like, you know, sometimes the lesion will look a little bit different or more definable in MRI versus CT. So there can be variability in that. Now, the important thing, if you're a radiologist, how do you like overcome that? Is you compare it to the prior and you remeasure the other exam on your own. So like if I'm looking at your scan like today, and I'm going to measure your lesion one way, I'm going to go back to your old scan and get the same lesion and measure it the same way. Me measure it the same way. And then I compare the measurements to both. So I have like an internal control. I will tell you that there are radiologists that when they're in a hurry or they just don't execute good practice, who don't always do that. They just like give the numbers or rely on the numbers of the prior. That's dangerous territory, because I think there can be discrepancies. There can be discrepancies. The other thing to keep in mind is that, and this is affected by the interval between scans too. Like if someone's getting a scan every 4 weeks, like a small amount of change may mean a lot. Whereas like if someone's getting a scan every year, a small amount of change might be fine, right? I mean, like whatever. The threshold for determining like whether something is worse or better is somewhat subjective and somewhat objective. So there are criteria that are used in clinical trials known as the RECIST criteria that give ways of like saying someone has progressive disease or stable disease or a complete response or a partial response. That's based on size of the lesions. And so some radiologists or sometimes after the radiologist reads it, another radiologist will specifically do RECIST on it. We'll use those terms, stable disease, progressive disease, partial response, complete response, as part of RECIST. But sometimes I'll be looking at a lesion and it may not be 20% bigger, but I look at it and it's like, this is bigger, right? It's objectively bigger. So I will inform the oncologist that it's larger. I will say this has gotten worse. So when we get to that impression point, right, I take the measurements and the findings. When I get to the impression point, I'm going to say better, worse, or the same, or mixed. Sometimes some lesions can get bigger, others can get smaller. We get mixed response in the same patient. So that part is important. And the way I do that really is by comparing to the prior exam. And sometimes I may have to go back multiple prior exams, because if the exams are too close together, the change may be so small that you might not be picking it up. And then you go back like 6 scans and you're like, oh, wow, this is like way bigger, right? So, you may need to go reference a few scans back over time to see something that's so slowly growing. But that's basically how we do it. And I can tell you that I wouldn't personally, if I was reading the reports, get too hung up in like the absolute numbers, right? Like the 9 versus 7 versus 8 versus 12 or whatever, right? It's more about like, does my lesion look bigger or smaller? Because there can be variability in how things are measured. And I see that like every day. I mean, I'm all like, I don't want to say every scan, but like my measurements between radiologists are often different by a few millimeters. That's super common. And not necessarily wrong. Like that's also important to note. Not necessarily wrong. It's just a different style, and you can just by having consistent style, try to make that determination of better or worse.
So are physicians trained on how to read images? I'll just give a scenario. Let's say that a patient is seeing their physician for results of a scan, and the scan says, maybe something changed from 3 to 5, and it's commented on it, it's bigger. Sometimes in the actual appointment, I will want the physician to pull up the scan and show me, and I'm just curious, how well versed are physicians in reading scans?
I think in my experience, that's very variable amongst physicians and the type of physician and the body part they specialize in. So, if somebody is a brain surgeon, they're probably pretty good at looking at like brain tumors, right? Because before they go and do the study, to do the surgery, they look at the imaging and like see the brain tumor to plan like what they're going to do. But they may not be great at looking at all the other findings on the MRI that are in the rest of the brain, right? Because their like expertise is brain tumors. Same thing, like let's say someone is a biliary surgeon, like a liver and bile duct surgeon. They may be very good at looking at imaging for, the tumor and its extent and how to plan their resection. They might not be great at like looking for metastatic disease. Okay, so I think that varies amongst people and their expertise. It also varies amongst like their interest level, right? Some doctors may have a particular interest in looking at images, and they'll call me and like have the images pulled up and be asking me questions about the images. And others don't like care at all about what the imaging shows other than what I'm telling them. And I personally don't think that there's anything wrong, like that second group of doctors, that's not necessarily bad, right? That's not their area of expertise. And honestly, you probably don't want like a non-radiologist interpreting your scans. That's bad. Like I see that happen a lot where like non-radiologists will be putting in notes like their interpretation of scans, and it's often wrong, very wrong. They don't know what they're looking at. They're not trained to do that. But at the flip side, it's very nice for a doctor to be like, I read a report, I say the patient has this lesion, the patient's in the office, for the doctor to be like, this is what the radiologist is talking about, this is what it looks like, this is what it looked like before, and you can kind of compare apples to apples, like right in front of you, with them kind of guiding you through that. I think that's sort of a bonus. So I think that like is a nice thing to have happen if you're a patient. But in terms of like being able to interpret a scan, radiology is like really complicated and difficult. And not only are they probably not capable of doing that, and it's not their fault, they could cause a lot of problems if they were doing it, because I don't think they would do it, correctly. And I think most physicians know that. Like, they probably don't want to be interpreting radiology studies because that's a lot of work and it's outside of their expertise.
Yeah. What about second opinions? Could a patient say that they want a second opinion just on a scan? And how exactly does that work?
So, second opinions aren't required, right? So, like, every radiologist in the country should be able to read like a basic cancer staging protocol, it's CT. But just like with anything in the world, right, there are widely varying qualities of what you get based on the quality of the scan you get, based on the like hardware that was used to do it, the type of scanner, and at some level, the person interpreting it, right? You could get your scan interpreted by somebody who's a subspecialized expert, or you could be getting it interpreted by a generalist, or you get it interpreted by somebody who's an expert in something else and just happens to be covering, reading oncology scans that day, based on the place where you went. So there is a lot of variability in the skill set of the person interpreting your scan. Likewise, another good example of that is if you get a scan in an ED, right? The ED read is not going to be the same type of read that you get as an outpatient scan that's read by a radiologist who's a body radiologist or whatever, versus an ED radiologist or that same radiologist working in the ED, because it's like a different question, a different setting, a different set of goals. So the environment where you get the scan matters too. So the question is, can a second opinion help you? And in some cases it can. In some cases it can. There's a couple situations in which, it's really indicated. One is like, there's something that seems wrong or unusual about the report, right? The report doesn't jive with previous reports. The report brings up something that doesn't make sense clinically, right? Your doctor's like, I don't know what this means. It doesn't make any sense, right? Then you may want to get someone else to look at it, right? That's completely reasonable. The other situation would be is if you are coming from someplace small and have only had your scans read, on a preliminary basis by, a generalist way out in the community, and then you're now getting transferred to like a larger center for care. Most of these centers, mine does, most of them have a mechanism for those scans being uploaded, and then we produce a new report. So like, I read 100 outside scans a month, and those are second opinions, right? They're second opinions. They're patients that have already had, I have the outside report, like maybe half the time I know what they said. But that is a form of a second opinion. And the reason why it's done is because it's nothing that those other radiologists are bad. That's not what it is. And actually, a lot of these radiologists are good, and I can't do their job. Their job is more general, right? They're able to read everything, and I'm much more focused. On the flip side, there are things about my focus area that I probably know more about and can maybe produce a little bit more information, right? So that is another setting where you can get a second opinion. We do also have patients who, they come to us for care and then they go home and get their scans there and they get sent to us and we read the scans for a second opinion, like in follow-up. So there are ways to get second opinions. The way to do it, the easiest way to do it is if you end up at a bigger center and they have a mechanism for uploading outside studies and rendering what's known as a consult. And I don't think that's unreasonable. I don't think everyone needs it. I don't think every scan needs it. I think it can be a little bit inefficient and maybe not the greatest use of all resources, but it is something that's available, and particularly in certain scenarios, it can be helpful.
So how would a patient know when that scenario might be helpful? So I'll share kind of a bit of my experiences, background, and context. So I have a very complicated case. I had a ton of tumors in my liver. My very first scan happened in the ER, and very much like you're describing. When I look back on those scans, they're like some of the worst scans that I have. There's tons of lesions that are missing. It looked like I had maybe 4. But once I had like a really good quality MRI, you could see I had 15 or more. And even so, I did go to another outpatient center when I was getting my MRI follow-up imaging for the first imaging that I had, but it was booked out everywhere. And so I went kind of a little bit further out so that I could get in sooner from a center that wasn't quite as specialized. And that might be kind of the worst MRI imaging that I've ever had. It's really hard to see. But I also know, I think they might have been using a different protocol, as you've kind of described before, if they were looking for something different. They were trying to see, are these lesions in my liver benign? And so they were probably using a different protocol, and that imaging looks very different. So, but for example, if I had like a very common cancer, or I was like, say I was going for like a mammogram or something like that, I imagine those are going to be pretty consistent at a lot of places. So how does a patient know which scenario might warrant a second opinion or seeking a higher quality scan possibly?
This is a tricky question, and there's like multiple questions in there. So starting from the beginning, one thing that I want to re-emphasize, which I think you mentioned, you said, but maybe it would have got lost if someone hearing you, is, you first were seeing in the ED and they saw like maybe 4 lesions. I'm assuming that was a CT.
Yeah, that was a CT scan.
And then they did an MR and saw 15 lesions. So that is pretty common, right? So MR, particularly for the liver, can pick up way more lesions than CT scan, particularly small ones. So MR is very good at detecting lesions. And that doesn't mean that the CT was bad. It just means that MR, for that particular question, was better. For that particular question. When it comes to like quality of the scan, there is variability in CT scans. There is variability, but it's much less than the variability that's in MRs. MRs have a huge variability from like, I can't read it, it's so bad, to like really amazing, right? So it's like this huge spectrum. And even within like our institution, like sometimes the MR turns out good and sometimes it turns out bad. There's technical reasons why that can happen. But the biggest reason why it can happen, sort of on like a macro scale, is like old hardware, bad protocols, bad imaging, newer hardware, better protocols, better imaging, right? And if you're going to some place that is smaller or has older hardware or is out in the very remote, and I don't want to say that remote is worse than like big city or anything like that, but their hardware may be worse, and it may produce imaging that's like not that good and is not going to add the information that you want. How do you know that that's the case as a patient? I mean, honestly, almost impossible to know that. You kind of rely on your doctor to know that. Like at some point, the doctor who initially sees you needs to be able to say like, okay, I sent Katie to like, this, he probably has some feel of the radiology practices in the area, or should, she, and, I sent her there, like I need to go send her to some other place to get better imaging, or to some other doctor who knows more. And as you kind of go up like the doctor pyramid, the radiology that's associated with them kind of comes along, right? So like as you get to more specialized cancer care, those doctors are familiar with places where you get better imaging because they're seeing so many scans, right? They have experience with that. So as the patient, I don't know how you would know that. I mean, maybe there's a way, but I don't know that you would know that. But your doctor should have some feel for that, right? Like, I don't want to send my patient to X place imaging because their scans are not very good and they don't give me much image. Or I've seen other patients who they went X and they said they didn't have anything, and then later on at Y they had something. So there is a lot of variability. I think it's most important on the technical side with MR. And I do think that as a general trend, kind of that follows more specialized care for better imaging. But once again, like, I mean, even at my own institution, which I think we do great technical imaging, like there can be a lot of variability between scans, and sometimes they're just like not very good for technical reasons. And we try to outline that to sort of say like this is limited. But that's kind of how it is.
When a patient is getting a scan, I'm just going to use a CT scan as an example because I've had more of those. Are there techs that are watching kind of live to make sure the images are okay before the patient leaves?
Yes. So, the technologists, well, technologists, just like doctors, like wide spectrum of quality. Now, a good technologist might be able to look at a CT scan and be like, you breathe, saw the patient breathe during the scan, and they'll just repeat it.
Okay.
Right. So the answer is yes, that they can look at it and have you repeat it. With MRs, that's even more important. Like the technologists, they're getting all these sequences. MR technologists have a difficult job, and it's much more hands-on because they have to set up these different parameters for sequences, and it's over and over again. And and a good one will be like, oh, I just did that sequence. It took 20 seconds. It looks really bad. We need to redo it. And they won't tell you that. They'll just redo it, and have you hold your breath again. So the answer is that yes, the technologist is looking at the stuff in real time and can, if they pick it up, redo it to make it look better.
Yeah, I think I think it really highlights kind of how nuanced all of this is. And the main reason why I asked about how does a patient know when they might need a, a second opinion for imaging was also just part of, like, I think when Julie and I share on this podcast, I think it's really easy for us to share really rare scenarios because we are patients that are in that rare bucket, but also acknowledging that a lot of patients may not need that super specialized care. Like I mentioned, like the mammogram scenario or something like that, right? I mean, I think just as you talked about knowing the right imaging for the right question you're going to be asking, if you're just going for like general screening, that there's plenty of places and scenarios that if you fall under a very common path, I think we kind of talked about like a lot of community centers know how to read and do FDG PET, right? And that's going to be similar most places. So knowing as a patient when you might be falling into like this is a pretty common scenario and people do a lot of these, that you might not need a second opinion or a second read of something as often as you might need something that's a little bit more specialized. And I don't know that it sounds like there isn't quite always like a nuanced answer to know that, but
I think the most important thing is that you have a doctor driving your care who knows when you need to go somewhere else.
yeah.
Right. That's really the key, that you've got an excellent doctor kind of at the point of this, because I think a lot of these things it's excellent for patients to try to it's essential. Honestly, I have my own health issues. It's essential for patients to manage their own, as much of their own health care as they can. But at some point, particularly when it comes to things like radiology, you really need that doctor who's seeing you up front to be like, this is rare and I'm not comfortable with it. You need to go to X. Or this other person over here can do better for you than I can, right? I need you to go see this person because they're the experts in this. And they should know those thresholds, for what they're good at. And then when you need to go get something else. And I think the same thing applies to radiology, right? I just don't know how patients, unless the patient detects that there's something wrong. And honestly, a patient's sense that something is wrong about their care should not be discarded, right? If a patient's I'm not really sure that these people know what's going on. If you're that patient and you think that, you probably should go get a second opinion, right? Not only because you might need the second opinion, but you'll be more comfortable if someone else tells you, actually, those guys do know what's going on, right? And so if you are uneasy about what you're seeing or reading or whatever, go get a second opinion. No one's ever going to fault you for that. But you also need your doctor to help guide you when a second opinion is required. It's time now for you to move on to someone else. And Matt probably has more experience with that.
I think there's 2 points that can probably be made. One is just to kind of piggyback on what you said. One is that I think it is important for people to remember that radiology is often just one piece of the total information that you would need to make, in the cancer world, I guess, a diagnosis and then a treatment recommendation, maybe more often the latter, right? And it's not super common that that a second opinion on a radiology scan is going to substantially change somebody's ultimate recommendation because it's just one piece.
Yeah.
The other thing I would say is that, to your point about good versus I guess, bad kind of centers or just with the respect to the quality of performing and acquiring the scan. I would say that just as someone who's a community generalist now, that treats everything, it's much more common to know of a very select few, quote, bad centers. Like most centers I know and send to and work with do an excellent job on most of the scans that we need to the point where it can answer the question that we need to answer. And it's not super common that we'll get into a place where I'll want a second opinion or we'll want to redo the scan at a different center. And I would just like to echo when that does happen, it's very commonly MRI. That's the one where I feel like I would agree is like there seems to be the most like kind of technical expertise required, and it's more common to see like a quote bad MRI that doesn't answer the question well.
Almost never that someone gives me a CT for like a consult, and I'm like, we need another CT because this CT is no good. Now, sometimes that'll happen if the patient moves or something like that type of thing, but not because of like a hardware problem. But with MRIs, I mean, it's pretty common.
Yeah.
That's not uncommon.
Right.
But
And one question that comes up that's related is like patients want to know, like, can I get my scan anywhere? Or like, where do I need to get it? There's a lot of considerations for that, but it's a good rule of thumb. Like, to your point, CTs, if you're getting surveillance CT scans, those are done well by so many centers. Like I've seen this in multiple states across many different cities, and they're always good. So I think that like patients can feel more comfortable getting a routine CT scan, whereas if you're getting a liver MRI, for example, which requires a lot of patient instruction and participation, and then a lot of technical ability to collect it well, that might be where your doctor might have like more opinion about where you should get it.
Yeah. I think that like that dialogue right there is actually like as a patient, exactly what I would have been looking for of like that's very helpful context and information, I think, for patients to evaluate the situation. Like you said, it can be really hard for them to know the quality of care, know to ask for things, know if their doctor would even tell them to go to somewhere else. But even just that context alone, I think gives patients a piece of information to understand kind of the ballpark that you're working in there. So kind of the last question there is talking about the variability of these scans. And we've talked a lot about how it's very nuanced. There's so many other factors you have to take into account. We hear a lot about AI being used in healthcare, and I think we've heard a lot about it. I think radiology was one of the first ones to kind of adopt some of these practices. How much is radiology involved in, or AI involved in radiology in both the interpretation of scans, as well as if there's any future applications, kind of going beyond just the interpretation factor?
yeah, so I mean, when it comes to like the world of medicine and AI, I mean, radiology is like a super hotbed for AI research. I mean, there's a ton of financial gain. So like anytime there's financial gain, there's going to be a lot of like investment in the space. And also because radiology is such a technology-based field, I think it does lend itself particularly well to AI innovations. And AI has the potential to help radiologists in multiple aspects. Number one, it could help with detection of things, right? Like an AI algorithm may be better at finding those lung nodules that you're talking about. It could also help with telling you what the thing is, right? So an AI algorithm may be able to take like some combination of imaging findings, juxtapose it with other patient factors, and then give you some deeper like interpretation of the scan that you might have gotten originally. Now, where are we with AI today? There are some AI tools that are out there and that radiologists use, and I have tinkered with them. We've tinkered with them in our practice. They're not like, some of them help to some extent, but there's not like massive game-changing AI in radiology right now. There's some stuff that can help, and I think there's a lot of stuff with potential. And I think ultimately what we sort of need is, the volume of radiology studies is just like, I mean, it's like out of control going up. Like with aging population and, less time with patients, more studies, right? So studies going up, but like number of radiologists not going up that much. So the real kind of goal of AI is that it would make the radiologist job easier and allow us to sort of do more work better. And so, I don't think AI is going to replace radiologists anytime soon. I think we're way far off that, at least based on what they've done so far. And we've been working with AI stuff not since last year, for many years. That's not happening right now. But I do think that AI, the next step, is going to be to really streamlining our efficiency and our ability to make diagnostic interpretations on large volumes of cases. So I think AI is something that, for radiology is radiology is perfectly suited to it. And it's just a matter of taking those next steps of development, which, just like anything, they take time and there's breakthroughs and, there can be stepwise improvements and things like that. And that's an area of evolution for sure.
Awesome. Well, I know we have asked a lot of questions. Julie, are there any that I know we had a list here and I don't think we've gotten a chance to get to them all, but are there any kind of pressing ones that we've missed kind of along the way?
Not necessarily, but I have a really niche question that I meant to ask earlier and got sidetracked, but I am actually curious about it. And it's, again, a very niche question. But it was when you were talking about the actual report and you went through what's on a report, the findings, and then there's a section of the impression. And I always notice that the radiologist that reads the report, their name is actually mentioned at the bottom of the scan. So it'll say read by XYZ. And then there's another line directly below it that'll say something like signed off on by ABC. And so I'm curious, does that mean that two people reviewed my scan? Or what's the difference between person A, B, and C reading the scan and person 1, 2, and 3 signing off on the scan?
So the reason why your scan reports look like that is because you're getting them at an academic center and a resident or fellow is dictating the scan. So we'll say
Okay.
dictated by so-and-so, and then it will say signed by so-and-so. So the workflow at an academic center is a little bit different for many cases, because what ends up happening is a resident trainee will read the scan, and then the attending will read the scan with the trainee. The trainee will dictate the scan, and then the attending will sign the trainee's report. So actually, two people have interpreted your scan, and that is a kind of a fringe benefit of not kind of, it is a fringe benefit of working in an academic center like I do, is that residents aren't as skilled as attending physicians in many cases, but they are another set of eyes, and they're all exceptionally smart. They're another set of eyes. So radiologists are just people. Stuff gets missed on findings get missed on radiology reports, radiology studies every single day, right? There are no findings that are 100% detectable. And maybe that's an overstatement, a gigantic mass is maybe, a finding that anybody could see. But 99% of findings in radiology have a substantial percentage of time when they would be missed, meaning the radiologist wouldn't see them. And that's not necessarily an error, right? That's, and I do a lot of medical legal work too. And this is where we get in these discussions, right? That's not negligent or bad. It's just there are things, we're humans, right? Some lesions are hard to see. Some lesions are not you get distracted by other lesions. And yet we have all these safeguards in place in terms of the way we do our job to try to prevent that from happening, from missing things. But inevitably, no matter what it could be the best radiologist in the universe, they're missing things all the time, right? Whether they know it or not. And I, read my own studies and follow up, and on sometimes I'll find stuff that I didn't see on the last scan. Maybe it became more apparent on this scan; it got bigger or something like that. And a lot of times, when you go back and start looking at old scans, you'll find some tiny ditzel that was abnormal, right? That was the start of whatever problem was there. But it's important to remember that radiologists are people, and things get missed. And just that second set of eyes, even if it's a first-year resident who's not that trained, can be very helpful because they may see things that like the attending radiologist might not. And so that, or might have missed. So that just kind of underscores the reason why you have the two names is because it's the resident and the attending. But it also gave me a nice opportunity to kind of share that, one thing that people need to remember about radiology, and Matt has said this several times, is it's not like the absolute truth. Right? And like radiology studies are subjective. And when you go back and look at radiology studies in the past with information from the future, it's very easy to trick yourself into thinking that you should have known all this stuff like back in time point A, like, oh, look at all this stuff that was missed. That's not how it works, right? That's not how it works. Life is not like retrospective, right? You get presented with something at time point A and you do the best you can with it. And, when you start to go back, oh, sure, you find they didn't see this tiny thing or that thing, or they didn't know what this was and it turned out to be important, or that wasn't important. That's all hindsight. So radiology studies are subjective. And when we see them in real time, we try to do our best to give you the most information and direct like what happens next the best we can, whether that's more imaging or a biopsy or whatever. And that's kind of our job. And it's a job that takes a long time to get good at because a lot of that is sort of experience and gestalt based. Like I see this thing, I'm not comfortable with it. Like I don't know what it is, but it bothers me. Or like, I see this thing, but I don't really know what it is, but honestly, it doesn't bother me. Right? And we can always take safeguards in that second scenario and be like, it doesn't really bother me, but let's get a follow-up anyway, whatever. But, that happens a lot. So it's not the absolute truth. It's not like Matt said, it's not like, sometimes I know what a tumor is, but like, it's not like I'm like, there is a nodule in the lung and it is blah, blah, it's a adenocarcinoma with blank mutations. That's not how it works, right? Like, it's like, there's this nodule might be a tumor is most common. And then we do more testing to figure out if it is a tumor or not a tumor, what type of tumor it is. And so radiology is one piece of a lot of information. It's an important piece. It's a really important piece. And a lot of decisions are made based on it, but it's not the absolute truth all the time.
It's very uncommon that we ever get absolute truth in medicine.
That's right. Even pathology is not the absolute truth. Right.
I think, so I don't know if, I was going to just ask if we can try to squeeze it in. You asked about AI, but are there any other emerging technologies or things that you feel like patients might be less aware of that you think are going to have a big impact on radiology 10 years from now? Again, asking you to predict the future, it's challenging, but.
Yeah, I mean, one of them is definitely AI. And I don't know where that's going to go or where we're going to be at in 10 years. Because I think actually, if you ask me, we're like not as far as I thought we'd be now from 10 years ago. Like we haven't made as much progress as, was forecasted. So AI definitely big. There's all sorts of improvements in imaging technology and hardware, but I think those are more like, I guess I would say like technical and less big picture. The biggest picture thing I do think that's out there that's coming online, I don't know if it's quite made it yet out into the community, although it might be, is this field of what's called theranostics, which is, it's part of nuclear medicine, and I'm not an expert in this, but basically what they do is you take a similar idea with a PET CT, you give somebody a compound that's radioactive, that has another molecule on it that binds to certain tumors. So that allows you to tell you where the tumors are. Then after you've done that, you can give the person another compound with like a radiation delivery source that can then be localized in the tumor. So what theranostics allows you to do is to like deliver radiation or treatment specifically to a group of cells or a tissue using a combination of using imaging, right? Using imaging and these molecular compounds. So I think that theranostics, which I mean like the combination of therapy and diagnostics, that's how they got that, is something that it's really new. Like this is something that even at like big centers wasn't really a thing like just a few years ago. But as that field grows and the portfolio of these molecules that are used to treat different tumors grows, and research in them grows. I think that's something that could really kind of transform cancer care, because, you know, a lot of the goal of cancer care is to try to deliver as much treatment as you can, whether that's radiation or a chemical or, you know, or a chemotherapy or whatever, to the tumor without affecting the rest of the person, because it allows you to treat the tumor more effectively. And I think theranostics is like a new branch of that, you know, of that tree of potential therapeutic options. So if you were to ask me, like, what kind of thing might affect a cancer patient in the future, near future, I would say theranostics is something that is like really coming online. There's a lot of research in that, and I think that's a pretty exciting field that, you know, could make a difference. We've gotten so much better with cancer therapy in general. You know, when I was a resident, which is like started in 2005, I would see patients with certain types of tumors that like nothing could be done and they would live like months. And I see patients now with the same types of tumors who are living for like indefinite years and years. We don't know how long they're going to live, right? We don't know how this could be super effective. So we've come so far. So, you know, nothing really surprises me at this point in terms of treating cancer. But I do think theranostics in the radiology realm specifically is something that, you know, has a lot of promise.
I love that you brought that up. It's actually like I think my colleagues would attack me if I didn't point out that it's kind of a collaboration between radiation oncology and radiology in the theranostic space. There's at different centers, different departments do it or they do it together. It is so new. We just opened our program like a couple weeks ago. And so I would agree with you, and maybe in the future we'll bring some radiologists on and radiation oncologists, and we'll have a theranostic show sometime. But
Yeah.
yeah.
I think that's, and to kind of maybe even frame it, because I know those topics can be kind of complex, I think, for patients. So when I think of like back to when I was initially diagnosed, like a way to describe those that I would have understood is, I think initially, kind of like we talked about how I wasn't sure what the difference was between like a PET scan and a different scan. I'd heard other people going for different things. You also hear how like radiation works really well in some types of cancers, but other patients don't respond. And that can have to do with like the biology of that cancer. And so this kind of theranostics approach is basically to say, like, how do you identify the person who is going to respond and give them the thing that they're going to respond to? So I think that like it's a really exciting area. I agree as far as like a patient for more personalized care. But one question I do have for you is like one of our kind of finalized ones with talking about, you talked about how different it is, like seeing imaging from patients that are doing really well that may not have done super well in the past. I'm curious how often and this one's kind of a personal question, how often you see a patient scan that you didn't expect to see like an exciting response? Like, do you ever have that like really exciting feeling from like being
Oh
able to see
yeah,
a patient responding to something?
yeah, and yeah, the answer is yes. I mean, when you're, I don't mean to be like, you know, I don't mean to minimize this, but reading cancer scans is fairly boring, right? Like in the spectrum of stuff that I do, it's kind of like rote work, right? You know, you're measuring these things and comparing them, and it's like most of the time it's like, you know, some small change this way or, you know, the other, whatever. You know, it's like you're like cataloging. It's not that interesting. You're not finding a whole lot of new things on them. Cancer follow-up reading can be kind of like mind-numbing. It can be difficult, monotonous. That's a good word, monotonous. But you see patients who have these like wild responses, you know, to treatment where like they come in with like just like cancer everywhere, and now they've been given some therapy and like almost look normal, and you're like, what has gone on here? And the first sort of era where we started seeing that was when immunotherapy kind of became a bigger player, because there were a lot of cancers that, you know, we were treating with chemotherapy and we'd kind of knock things down, but it was very temporary. But when we started getting cancers where like the cancer had a specific thing that could be targeted with immunotherapy, and you targeted it and it was like just like vaporized all this tumor, the first couple times you saw that, it was almost like you didn't believe it. Like, he was like, this can't be right. Because you've seen so many of these cancers, and that's like never happened. Right. So, yeah, when you see somebody who really responds, like, that's a good feeling. I mean, the weird thing about radiology, or one of the weird things, lots of weird things, is it's impersonal. Right. Like, I don't know any of these people. I mean, I know Julie, but that's it. But when I'm reading somebody's scan, I don't know them at all. Right. I've never seen them. I'll never talk to them. Like, there's almost no patient interaction in radiology. But you read their notes and you see what they talk to their doctor about, blah blah blah, and you kind of like develop like this sort of like sympathy for them, or you see their lesions and you're like, this sucks, right? Like, this is bad, right? So it goes both ways. But when you see someone that gets really better, that is rewarding for everybody. It definitely makes you feel better about like the medical system in general, that this person could see this level of improvement. And yeah, we do see patients now who, I'll tell you, there's a lot of types of tumors or findings that used to be, quote, a death sentence. Like, there's no way we can treat lymphangitic carcinomatosis. Like, that's a good example. When I was a resident, there's this type of cancer spread in the lungs called lymphangitic carcinomatosis, where the tumor grows in the interstitium. And the teaching was that if you had that finding for any reason with any cancer, it was like several months, and there's nothing you could do for it. And like, now all the time, we see patients who get better with that. Like, it's just like another form of tumor, and there's all kinds of immunotherapy and chemotherapy that treat that. And I've seen people cured of it and never came back. So, I think that the take home point is that, like, we don't see the patients, but we are sympathizing with them in many cases, because we're reading these images. And also, like, the possibilities for patients in cancer treatment now are very wide. And so don't try to keep a good level of optimism. You don't want to be like unrealistic, but a good level of optimism, and realize that like things have come a super long way. And there's a lot of questions that are unanswered in terms of like the benefits of therapy. Some therapies work and it's like, well, that worked, and we didn't really know why. It worked a lot. So it's a different world out there.
Yeah, I think that can be a really good like thing for patients to. I'm glad we touched on that, because
Yeah, that was a great question.
A patient, it can be, especially as we talked about some of these things, like missing things on scans and how normal that is. Like, I know as a patient, like, that can feel terrifying. Like, oh my, what if something was missed on my scan? And so I think that brings a lot of hope back to this, of that this is all developing and everything like that. But again, it kind of just touches on that scans are just a small portion of this. And there's so much more at play that are bringing better outcomes to patients, and it all works together.
That's really well said. Yeah, I'm glad we touched on it. Seems like a good place to end, actually, unless anybody has any last remaining thoughts. This is great. I really appreciate your time, Costa. I think this episode is going to be really well received by patients, and I just appreciate all the information you shared with us today.
No problem. If we want to do this again in the future with a new topic, we definitely can. Thanks for having me.
Okay, thank you.
Thanks a lot.
Have a good evening, guys. Take care.
Thanks so much.
All right, you too. Bye.
Bye.